Muscle growth. No, actually, first we do it first 4 minutes. It's kind of a bit you've got to go hard. But it's these last bits which is great for us. Fun. Yeah, I think it's going to end soon.
Do you know how to put in laptops? Did you get it? Okay, cool. Yeah.
Speakers that have
yeah, she's got a laptop. She doesn't know it's better does she plug her laptop in or does she put it on a USB?
It'd be quicker if it's on a USB, but she can plug a laptop in whatever she
first time you've actually rotated away from your core hospital that you went through with basic training for an extended period of time and seeing how other places do it. So again, really interesting, and often if you do that right, you might find yourself landing a job as a consultant in one of those hospitals. For most specialties, there's no exit exam. For some, there is. So haematology has a lab-based exam at the end of that 3 years. So you're getting pretty sick of exams by that point, having been through so many years at university. And it's an amazing feeling when you finish that basic physician training exam and kind of think, that's it. Don't need to actually sit any more exams for the rest of my days. Something you guys will appreciate a bit down the track. Some specialties have additional training for various procedures, so you can get a bit more honing of skills, angiograms, scopes, that type of thing. Some people will go overseas for that 3rd or even 4th year and do a fellowship to really get some specialist skills in a certain area. Not necessary, but encouraged, and just a great year again to disrupt yourself, go and do some stuff that's different. And if you don't have a family at this point, it's just such a nice time to escape and go and do something for yourself. Live in a place where you might not have lived previously. So just let you know a bit about Royal Melbourne. So we're part of the Greater Western Consortium. These are the hospitals that are involved. Got about 120 BPTs over this 3 years. We rotate people between most sites. We do reasonably well in terms of the exams. So we normally have somewhere between about 22 and 24 sitting the written, and we normally drop maybe 1 or 2 in terms of being unsuccessful. And in the clinical exam, we normally drop just 1 or 2 as well. So we've had a year where we've got 100%. National average is about 65%, so we're probably doing okay. Part of that's just being a selection bias. You guys are good students and become good physicians. But also, we like to think we've probably hopefully added a bit of value to you as you come through. And this roadblock I was talking about, exiting basic training and entering advanced training, we do reasonably well on as well. We get people, most people who finish with us will go through and get an advanced training position, maybe not at our hospital, but at different hospitals around town, around the country. So we really think it's a good place to train. I'm not trying to do too much of a sales pitch, but you guys have seen all the construction around here, the Peter Doherty Institute, the VCCC, the Parkville Precinct, the WeHi, all of the research and various opportunities that are existing, and it makes sense to think about this as a really good place to start your career. So what should what would I like you to think about? Well, think about what you think your lifestyle is suited to. Think about your family and what you think you might want to do down the track. Your hobbies and also sleep. So some specialties, they essentially give up their 30s. They give up 10 years of their life and they don't do much other than live in the hospital and miss out on sleep and go from being nice, caring people to pretty angry people sometimes. And then then the gates open and life's good again. But it's you've got to think, is that what you want? Where do you want to work? Think about this, and one way to think about that is also to look at where you think there is going to be an area of need in the next 5 to 10 to 15 years. So think about our society. We've got an ageing population. Not everyone who gets diabetes is going to see an endocrinologist. Not everyone who gets an infection will see an infectious diseases doctor. Not everyone who has a heart attack will see a cardiologist. A lot of this is going to be managed by general medicine people with this ageing population. So I think general medicine is probably on the cusp of becoming a really highly valued specialty. And if you would train in general medicine and you set yourself up on the outer metropolitan kind of Melbourne, or even just somewhere like Ballarat or Geelong, or somewhere that's an hours down the road, and you had some skills, and for example, you've done some bronchoscopy or some scopes, you're really setting yourself up to be quite a valuable asset to a smaller or medium-sized hospital. So have a think about that kind of dynamic. If you're, and most of you probably are, excellent at IT, I think IT is really going to revolutionise the way we practice. And some guys coming through at the moment who are really IT savvy, clinically excellent, and just trying to marry those two areas together, they're going to be absolutely invaluable to the hospital as they try and streamline things with IT networks and electronic medical records, electronic prescribing, referral systems, and really make themselves valuable. This guy is not even finished and he's been basically guaranteed a job by the CEO because he's so good at this kind of stuff. Think about so the way that this is really happening in the US, that fee for service, which is where you have chest pain and I do an angiogram on you, I get paid, which is not a great system because you find that everyone just with the slightest bit of chest pain gets an angiogram, not in the public system but in the private. A lot of health insurers are starting to move towards value. How have you added value? We're going to pay you for the value that you have added. Did you prevent that person from having a heart attack? Did you, modify their blood pressure, treat their cholesterol, get them to stop smoking? I think this concept of fee for service is probably going to drop away. And so being well-rounded, being proactive, being organised, thinking laterally, I think are going to be really important skills that are going to be valued and remunerated very well in the future. So have to think about that. Ultimately, I think do something that you find interesting. You get one opportunity to kind of choose your career, and once you've gone a certain way down that path, you can't necessarily backpedal and go back and be a registrar or resident again. So it's good to have a really good think about it. Think about what you enjoy, because that's probably where you're going to do your best work. Every one of us works hard when it's something we enjoy and are really immersed in. Flip side of that, don't stick at something that you find boring. Don't worry too much about the money, as I said earlier, and ask lots of questions to people that come through, and why do they choose this and why are they doing that, and really try and obviously there's a bit of a survivorship bias. People are going to sell their specialties because they want to believe that what they're saying is true, but canvass lots of opinions and try and balance that out and see how you go. So I'm more than happy to take some questions if people have some. Yes?
Hi, yeah, that's me. Sorry, thank you so much for the summary. I've got quite a specific question which
Sure.
you may not really relate to. In terms of family aspirations and perhaps being a female going through physician training, what are your thoughts on allowable time in terms of taking time off and coming back to do training? How does it work?
Yeah, so the college is acutely aware that they have not been as flexible as they could have been in the past, so there's a real push, and by the time you guys are ready to come through, I think things will be much better. So many hospitals have opportunities for job share, and there's different ways of doing that. You can do week on, week off, which is really challenging because you need to know your patients on Monday morning, and if you just sometimes that doesn't work quite so well. But there's lots of novel ways that are starting to come out. Interruptions to training are entirely permitted, and I guess the thing you need to be conscious of though is that as with all of these specialties, as with the huge number of trainees, medical students coming out of medical school, things are just getting a bit more competitive every single year. That said, have your family when you're ready. It's not necessarily a career ender, career alterer, anything like that. There's plenty of stuff you can do. So if you were, for example, to push through and get 3 years and have your family afterwards, many people just do a session, so no one ever tells you what a session is, but there's 10 sessions in a week. It's 3.5 hours, so it's about enough time to do a ward round or do an outpatient clinic. So some people are employed to do a session a week or 2 sessions a week, and they come in and they do outpatients, and they leave, and they don't have to have the phone on, and they don't have to follow up on patients or take phone calls when stuff's happening at 3 a.m. in the morning. And that's really for a period of time in your life, that's a really satisfying way of keeping your hand in the game, but also having time with your family. So I think of all the specialties, probably have to think about this, but this is certainly going to be a lot easier to manage as you have your family and see your family grow than some specialties, which really demand you to be on site at certain times and for certain periods of the year, the night, the weekend, the holidays, public holidays, all that kind of stuff, which is really, it's a really challenging time. Now that's not to say that there's BPD2s and 3s, you don't work weekends, nights, and there's all that kind of stuff, but life just miraculously gets so much better once you emerge on the other side of that. And it actually gets a lot better after basic physician training because you're often not doing nights, depending on your specialty. You might have the phone go off, but doesn't necessarily mean you have to come in and do stuff unless you're choosing certain procedural specialties. So I think from a family perspective, this is actually a really good option. Now, how does it marry up with general practice? can probably ask this question again later. But there's plenty of young females having families, and even fathers who are I'm a recent example. I've got a 3 and 6 year old, and spend not heaps and heaps of time, but I certainly get the things that I need to get to. Whereas I think if you're waiting for a surgical list to start, or on your shift till 10 p.m, that's pretty tough.
Yeah. Cool. Thank you.
Yes.
I just had a quick question about sort of how do you make your decision, like what influenced you into physician training?
Yeah, so I mean, I really like the idea of being a surgeon. I thought that's it's decisive, you're proactive, and you walk around the hospital and they're confident, and you think that's the decision maker I want to be. But I suppose I got really hooked into the problem solving of physician work. In particular, I did some work on an infectious diseases unit, and there's a guy there called Peter Stanley who's got grey hair. Just turned 70, so this would have been a little bit earlier. But I was talking about this, being interested in what you're seeing, and so for him, he, I just remember seeing him absolutely chuffed at seeing something extraordinary that he'd never thought he'd see. And you think, this guy's been doing it for 25, 30 years. That's a pretty good kind of outcome, pretty good life if you're still interested in what you're doing that far down the track. So that was a really big factor for me, that I like that kind of career-long kind of, I call them aha moments where you're like, it's amazing. The other thing for me was the training outside of medicine. So I like doing my sport, and I thought, geez, do I really want to give up 10 years where I'm in here at 5:30, 6 o'clock, and I'm leaving maybe when the work is done, which is often late at night. And I just thought, no, I don't really want to do that, and I don't put my wife through that. And so for me, it was ultimately not that difficult a decision. Now, I don't drive a Porsche, I don't have holidays in Mallorca, I don't do all that kind of stuff, but some of my colleagues do. Some of my colleagues are doing really well. The guys I went through with who are doing very well from a monetary point of view because they're orthopedic surgeons or plastic surgeons or whatever it might be. That's fine. I think each to their own. But the balance, I think, is that you get your lifestyle. I think that's really important. Yep.
Can you tell us about why you decided to do gen med and infectious diseases? Is that the trend to kind of increase competitiveness, or?
Look, there's a few different, career directions you can take after you finish your specialty training, and it's gotten a little bit harder because in the last couple of years, the college have said to be a general physician, you have to actually do an extra year of physician training. But when I went through, you could actually just call yourself a general physician after you've done your ID training or any of the other specialties. And so some people choose to do a PhD, and I didn't do a PhD. So PhD is often 3, 4, 5 years, and if you think you did 3 years of basic physician training, you did 3 years of ID training, so it's then 3 years since you did any basic physician training in general medicine. And then if you went off and did a PhD, it might be 6, 7 or 8 years since you did any general medicine. So for me, I thought I really enjoyed general medicine, and a lot of ID is gen med, so 40 or 50% of people in hospital have an infection, and it makes you actually a better ID doctor to know the non-infectious causes of a lot of different things. So I think it enhances your ID, probably you make a good general physician because a lot of the general physician stuff is ID. And for me, the choice of whether to go and do a PhD versus whether to do a clinical work and dual training was made easier by the fact that I just didn't want to spend 5, 6 or 7 years away from general medicine. As I said, a lot of this knowledge changes very rapidly, and so to have such a long period of time away from the specialty, I think would kind of hurt you to some extent. So I was more happy to drift into that training clinical kind of role. And the thing that kind of fell in my lap a little bit is actually the physician education stuff. So I did quite a bit of training for the junior doctors. It's really actually good to have non-clinical work, so we're not just going and seeing patients. We're dealing with young people, they ask good questions that often stimulate you to think about what you do and change your practice and justify why you do it. So the teaching element's really, really satisfying and probably key keeps you on your toes, and makes you probably a better doctor, I think, along the way. Now, there's plenty of opportunities to teach in a public hospital, less so in smaller hospitals, not too much at all in private, although that's changing. But yeah, the decision for me was, one enhanced the other. Seemed like a nice partnership, and I think you are more sellable to different hospitals. So just to give you, I work, it sounds horrible, but I work at 4 different public hospitals. I'm at Royal Melbourne, do some ID and some general med, do the physician education stuff, and do some ID at St V's, I do some general med at Peter Mac, and I do some ID and some general med at Northern. So yeah, I'm scattered all over town at the moment, and that's junior consultant, and then as you start to get a bit more time in different places, you drop them off, and you might find yourself in one place. But I actually really enjoy moving between different places. It keeps things fresh, and I quite took forever, but I think it's actually quite enjoyable. So yeah, I think that's the reason I'm married to well. Did you have a question?
Sorry, I don't think I have that.
Oh, yeah, time. Yeah, very good.
Can we please thank Dr. Sam Henning?
Say if you see me on the wards or you want to come and ask a question or pin me down, more than happy to talk. Usually pretty busy, but very happy to talk. And I actually race off in 6 people now, so thank you very much. Catch you later.
Yeah, okay. See you.
So we've got Dr. J. Dub, who's actually come across from across the road from ICU at the moment, so we'll try and squeeze him in now. Yeah, we got Terry introducing. Okay, that's all right. We'll jump straight into it then.
How do we just get onto that one?
So.
PC?
What do you want to do? You want to put your stuff on? Or
Yeah.
just unplug what I did? Have you got a Mac here?
Oh, I use some like a man. Perfect. Easy.
Oh, yeah, you look too professional.
All right. Thanks, guys. Apologies to the sponsors. I've sort of muscled in, I'm afraid. Sponsors out, but I'm on over the road, so the guys have been kind enough to squeeze me now. I'm Jay Dub. I'm an anaesthetist and intensivist over at the Royal Melbourne. Anyone from the Royal Melbourne here tonight? A few people? Yeah. I know some faces. Good. So you might have seen me around on the wards. This is unplugging. So I've been asked to speak about how you become an anaesthetist and or an intensivist. Anyone kind of interested in those career pathways? Yeah, maybe a few. No one wants to run up too much. So I guess similar to what I'm sure Sam just did, I might just talk a little bit about kind of what a work day for me involves. Unlike Sam, I have a kind of opposite job mix where I'm entirely at the Royal Melbourne. So there's benefits and detriments to that, as we might sort of touch on briefly. I work over the road full time, and my job mix is a couple of days a week in theatre. So I'm essentially a half-time anaesthetist, half-time intensivist there. And I'm also employed by the uni as one of the sub-deans over at the clinical school in education. So what does that mean? All of you by this stage, most of you fourth years, a few third years, most of you fourth years, yeah?
They're first years.
Your first years? Oh, this is really early. I must have missed that answer in the emails. So you won't have jumped into theatre that much yet, but you will. Most of you in your clinical schools will do anaesthetics as an MD2 next year. So you'll see a little bit more about what anaesthetists do. But essentially there's a real mix these days. It's much less about just gassing, which is what it used to be. So for me, I spend a lot of time in theatre doing anaesthetics. For whatever reason, I tend to do a lot of neurosurgery and trauma, as well as the ICU patients I tend to get lumped with in theatre. We do pre-admissions clinics, so we assess patients in terms of their readiness for theatre, how we can optimise things beforehand. Anaesthetists are all pain specialists to a greater or lesser degree. Pain specialisation is a separate specialty these days as well. But we partake in pain rounds and manage post-operative pain as well as chronic and neuropathic pain. And increasingly we're asked to be perioperative physicians. People heard that term before? Yeah. Sort of a bit of a jack of all trades. As patients turning up for theatre become ever more elderly and more complex with increasing numbers of medical comorbidities, there's a lot of work that goes into managing those patients through the perioperative period. So perioperative medicine is a lot of what we do. As a public hospital specialist, there's a lot of non-clinical duties that we're called on to do. So I've been lumped with a fair bit of research and teaching portfolios. And increasingly simulation is becoming a big thing, as you guys I'm sure have already started to see in your undergraduate or postgraduate medical education, but particularly now for specialty training in anaesthetics as well as ICU simulations on the rage. In terms of intensive care, so it's a similar sort of thing, lots of ward duty. The on-call for ICU tends to be a bit more onerous. There's a bit more of it, and we might talk about work-life balance a little bit. And the same sort of smattering of non-clinical roles is what I'm lumped with as well. So how do you train to be an anaesthetist or an intensivist? What are the sort of training pathways? Well, the Australian and New Zealand College of Anaesthetists are the accrediting body for anaesthetic training across the region. So anaesthetic training is a 5-year specialty, 5-year full-time. A lot of people would do that part-time, particularly as there's increasing numbers of females coming through the training program. It's a very female-friendly, family-friendly training program, so part-time training is very much approachable and doable. Your basic training is an 18-month period after your introductory training. So that's sort of 2 years during which you do your first exam. All right, it's a pretty tough exam, but most people get through that without too much trouble. And then there's 2 years of advanced training that follows. And basically anaesthetic training is a nice continuum of, very supervised practice at the start into things where you're really never left alone with a patient on your own at all. Gradually building up through your advanced training years to increasing complexity of patient management on your own, culminating in the final exam, which is taken in your 3rd and 4th year, usually your 4th year, and then after which you have a fellow year, where essentially you're operating as a junior consultant. So autonomous practice, the chance to really sort of spread your wings as a junior consultant in still a supervised practice. Anaesthetic training in Victoria has changed a little bit over the last few years. So in 2013, all the hospitals came together and said it's all getting a little bit hard trying to work out, who we want, and we want you, but that other hospital wants you, and you say yes to us, and then you jump ship for them. So it's now coordinated across the anaesthetics training scheme. There's 3 regions: Northeast, Northwestern, Eastern and Monash, and these are the hospitals that are affiliated with each of these training schemes. So what prospective anaesthetic trainees do now is they apply to one of these training schemes, okay? And there's members from each of these hospitals that sit on the interview panels. And it makes it for a much more sort of transparent and robust selection process. How do you get into training? Well, before you're allowed to apply, you've got to do 24 months after your medical degree. So that's an intern year and at least one other year. In practice, most people will have also done a 3rd year as a so-called critical care HMO3, okay? People have heard of that, the critical care year? Yeah, maybe? Not yet. Once you get the hospitals a bit more, you'll hear about that. And in that year, you tend to do a few more critical care type rotations, anaesthetics, ICU, emergency medicine, that sort of thing. And it's a pretty robust application process. Lots of people want to do anaesthetic training for whatever reason. And so, as with most things, it's a very opaque, it's a very transparent, what have you done? What's your academic record like? What are your references like in terms of getting on? As far as ICU goes, it's a little bit longer. It's a 6-year full-time degree. For dual trainees, you can cross-accredit. So I certainly cross-accredited a little bit of training along the way. So for me, it actually only added an extra year of training to my anaesthetic time to get my ICU ticket. It's a little bit harder these days. In your 6 years of training, most of it's ICU. There has to be a year of anaesthetics. So there, already, you can see potential for a little bit of cross-accreditation. And there has to be a year of medicine time as well, of which 6 months has to be acute medicine. You can do an emergency for that. After your fellowship exam, they want you to do 12 months of so-called transition year. And that's akin to the anaesthetic fellow year, so sort of junior consultancy before you're ready to go. Traditionally, there wasn't a selection process for ICU training, and there's lots of political debate about whether that's led to a workforce supply-demand mismatch. So the college has actually listened to some feedback, and they now are selecting trainees, which is good not just for workforce planning, but to ensure quality of trainees coming through. It's not that hard to get into ICU training though. You just need 2 references from a reference from 2 intensivists that say that you're not a monkey and you can look after patients okay, and you're pretty much in. So I thought this is, I don't know how well this is projected, but I thought this is interesting. This is the medical workforce planning body, which is affiliated with the Australian Medical Council. Every triennium they release workforce modelling. You can Google this on the internet, you can get it all, which, I mean, it's a bit early for you guys, but as you sort of come to the end of your training, it might be useful to see what people are looking at. So it hasn't projected that well, but you can see these are the top 3 picks for both males and females at the final year of their medical training. What do people want to do? So for anaesthetics, about 9% of all males want to do it as their first pick, 5% of all females. And if you include all top 3 picks for all final year medical students, 22% of everyone is kind of interested in anaesthetics, 14% of females are kind of interested in anaesthetics. Once you get to the end of your intern year, numbers have fallen off a little bit. So top pick is only 8% of males and 5% of females. So I think that's sort of, interesting. We'll look at actually what people end up doing in a slide. In terms of ICU, lesser numbers, so 3%, 2%. And again, that's dropped off a little bit. So less than 1% of all females want to do ICU training by the end of their intern year. So it's still considered a little bit of a rarefied thing for whatever reason. I think perhaps the long training program and less flexibility and perhaps work-life balance factors into that. In terms of numbers of anaesthetic positions, well, this is actually what ends up happening. So in terms of numbers of positions of people that are in training, this is a graph. Have you guys seen this graph before or tonight? No. So about 6% of all trainees are anaesthetic trainees and almost 3% are intensive care trainees. You can see that's completely eclipsed by physician trainees, as Sam's just talked about, 23%, about the same doing general practice. So although attractive, these specialties are still a pretty small minority of what people end up doing. In terms of gender, there's a pretty good gender split these days in terms of anaesthetics and ICU. So you can see 44% of all basic trainees commencing training in anaesthesia are females, and in ICU about 40%. So that's good, and that's doing good things to redress the traditional imbalance in both of these specialties, very male-dominated professions. You can see how things have changed over time there. So in anaesthetics, it's pretty stable. In ICU, you can see it's really increasing. So back in 2010, only a third of ICU trainees were females, so that's good. In terms of the existing workforce, in anaesthetics, really it's still a smaller proportion of females. So only 27% of all anaesthetists are females. So you can see that almost 50-50 balance will change the face of the profession over time, which is good. And ICU, even less, only 16%, 17% of all working intensivists are females. So I think change can't come soon enough, which is good. In terms of changes in numbers of anaesthetists and intensivists graduating, lots more anaesthetists are getting pushed out, okay? And there's a little bit of modelling that suggests a slight oversupply of anaesthetists as time's gone on. So that's of interest to all of us working in the profession and those who are starting out. ICU, it's fallen away in recent years. So these are sort of interesting figures if you're kind of looking down the track. Anyway, how do you get a taste, for whether you want to do these things? It's kind of hard. So unlike your medical training where you're going to be attached to surgical units and physician units and you're going to do ED time, it's hard to get a good exposure to ICU and anaesthetics. Certainly at the Royal Melbourne we're trying to change that. There's a little bit of in-theatre time and ICU time, but as junior doctors you almost have to commit to do these things before you kind of know whether you want to do them. I suggest very much doing a critical care year if you're interested in them. If you're lucky and you pick your right internship, you might be able to do an anaesthetic rotation as an intern or a PGY2. But generally speaking, your critical care year is where you really get an exposure to what these things are about. That's pretty much all I wanted to sort of talk about ICU and anaesthetics. If you want to kind of read more into it, both websites have really good descriptions of how to get onto the training program, what it involves, selection processes and so on. But with the short amount of time remaining, are there any sort of simple questions that you've got? You can certainly feel free to drop me an email if you see me around the Royal Melbourne. Get on to me. Quick questions about what it involves. No? Done? Easy? Right? Thanks.
So I just want to quickly introduce one of our sponsors, Buongiorno. We'll tell you the services they can offer you now and when you graduate.
want to take up too much time. We are from Bonjournos in Melbourne, so Ben and I work for a company that specialises in financial services for doctors and dentists. I find these things very difficult to come and do because, let's be completely realistic, most of you in the crowd probably won't require our services until about 2022. These things are often quite difficult. So what we've got today, we've got one of Ben's clients, Shakira. We did a video with her probably about 12 months ago now. Just gives a bit of an insight into what to expect in your final year and going into your internship. So just have a listen and hopefully you find something a little bit useful in it. Sorry.
Yeah, that would be good.
I think about your study, maximise the time away from your desk. It's the last year you've got as a student, and those years are amazing. So make the most of it, both study-wise and outside of uni as well. I took a lot of holidays. I took a permanent loan actually, and made the most of that money, and had a lot of little time off breaks as well, which was cool. You've got to, while you're at the hospital, make your time really efficient. So, you know, be practical about what you need to learn for intern year, and make sure you're learning those skills, you know, cannulas, catheters, things like that you'll be doing on a daily basis when you're first year at the hospital. I think be prepared. All interviews are slightly different. Talk to people who work at those hospitals, learn their values, you know, learn about the style of interview that you're going to have. So some are group interviews, some are individual. Be on time and dress the part. PMCD put on a lot of good talks, and they've actually got a really good website that has a lot of the key dates and things you need to submit and deadlines. So just as long as you print that out, have it on your wall, I think you'll be pretty well organised and won't have too many nasty surprises. I don't think so. I had a really good final year. It was probably the best year I had at uni. It's a time that you finally feel quite comfortable with your knowledge and just excited about finishing and getting into that next period of life and getting off Centrelink and making some money. I think probably the thing I enjoyed most was that camaraderie you build with your fellow interns. I used to catch up a lot with people that I did uni with, and you know, we'd all laugh about the silly things we'd done, or the embarrassing things we've done in front of senior doctors. It's something that you'll all go through, and it actually is quite a bonding experience. It was also nice to be finally making some money after being a student for so long. Things that I probably enjoyed less was being tired and just having less time for sort of personal interviews. I think speaking to HMO2, so people who've graduated a year before you, just getting a heads up on what to expect, and even your registrars, it's really good to know that what you might be experiencing is normal, and everyone goes through their frustrations, everyone feels tired, everyone feels embarrassed at times. It's completely normal. You're going from a student to a doctor. It's a huge transition, and don't feel like you're alone if you've got questions or concerns. I think that it's as much as knowing having your medical knowledge up to scratch and knowing where the best resources are. It's focusing on your interpersonal skills at the hospital. You see some interns who have such a different experience to you just because they've annoyed a few nurses or annoyed a few senior doctors. your life will be so much easier if, you know, you focus on maintaining great relationships with the rest of the staff, you know, multidisciplinary teams, and yeah, it makes a huge difference.
So guys, that's Shakira, and I know that it is a fair bit of time before you do go into that internship year, but we thought we'd put it on there and hopefully it does help you out. As Mitch mentioned, we're from the Bongiorno group, and is there anyone here that's working right now? Yeah, beautiful, beautiful. For anybody that does continue to work into their student years, is that at Bongiorno's we offer free tax returns, and we've also got a student loan that will become relevant to you guys in your final and penultimate years, and that loan was created to give students a little bit of a hand, you know, if they're doing their elective or they're going on holidays, and it came about, we had a lot of interns that were coming in that were saying, well, look, it's fantastic to earn some money at this stage in my career, but while I was a student was realistically when I really needed it. So that's how that came about. It is specified for medical practitioners, and I won't go into too much detail, but it is an amazing deal. And you know, we offer these sort of things to medical practitioners. The next one up there is a bit of a disclaimer that pretty much just says that anytime you listen to someone talk about financial planning, it is general advice in nature. So we have to put that one up there for you guys. But my name is Ben, this is Mitch, and please, if you do have any questions about the finances, the free tax returns, a student loan, or right through to you coming in as a medical practitioner, please do run those questions by us. We do specialise with medical practitioners, and we're here to help. Guys, thanks so much for having us, and I hope you get a lot out of it tonight. Thanks very much.
So our next speaker is Dr. Yvonne Chow. Please make sure you do stay to the end. I know it's been a really long day, but we've still got some really great speakers to come. Without further ado, Dr. Yvonne Chow. She's a plastic and reconstructive surgeon.
Oh, sorry guys.
Yeah, come.
Yeah, how come nothing else done? Fantastic. There's not many of you here, but that's okay. I understand what it's like to be a medical student. And in fact, being a medical student, this is such a privilege to talk to you because you guys are the face of Australian medicine in the next 10 to 15 years. So God help us all. Look, really, I'm just going to tell you a little bit about being a surgeon and my pathway to surgery. Everyone has a slightly different pathway. By the time I finished medical school, I didn't want to do medicine anymore. So, not that's not meant to disinspire you, but I'll just chat a little bit about my specialty that I'm very, very passionate about, and I hope that you will be passionate about after my talk. So, the surgical specialty is really, I forgot to say, I mainly work at Monash Health, so you probably are all from Melbourne, so I'll probably never ever see you again. But if you do come that way, please feel free to ask me questions. There's general surgery, and general surgery incorporates those things that I've just listed there: colorectal, which is bowel, upper GI, which is your stomach, hepatobiliary and trauma as well. There's vascular surgery, orthopaedic surgery, neurosurgery, cardiothoracic surgery, urology, ear, nose and throat surgery, and of course there's plastic surgery, which is the best specialty. Now, when most of you think about plastic surgery, I'm sure this is what you're thinking about. Okay, this is cosmetic surgery probably gone wrong. Okay, so I know today's slide, we do this, but it's a very small part of what we do as plastic reconstructive surgery. Why we call plastic surgery plastic surgeons is because we, this Greek guy called, I can't actually remember his name, but plastikos actually means to mould. and that's where plastic surgery was derived from originally. This guy is an Indian chap who was a teacher back in ancient times. He's the grandfather of plastic surgery, and in fact this is in teaching in the very early ancient times. And Gaspare Tagliacozzi is also our modern father of plastic surgery, and this is in the medieval times. And basically, I'll show you this quote from him: "We bring back, refashion, restore wholeness the features that nature gave us, but chance destroyed, not that they may charm the eye, but they may uplift the spirit of the afflicted." So although sometimes what we do is not actually crucial and life-saving, we uplift the soul. So Benny Rank is a surgeon, the grandfather of plastic surgery in Australia. He died in 2002, but many plastic surgeons have been trained by him. I'm just going to tell you a little bit about our curriculum, because you're probably looking and go, oh my God, there's so much to learn. Well, there really is. Because when you go and start studying, there is the surgical sciences and principles. So that is anatomy. Do you guys even cut up a body these days? Oh wow, that's fantastic. Oh, that's great. I thought it would have all been 3D simulation. There's physiology, there's genetics, there's your biochemistry. But then we go on to craniomaxillofacial surgery, and we have things that we need to learn about, like cleft lip and cleft palate, bony deformities of the skull, facial fractures. I'm just going to give you a quick overview of what we do. Facial soft tissue things, such as cancer, so basal cell cancer, squamous cell cancer, melanoma. That's us cutting out a large basal cell cancer off someone's lower eyelid, reconstructing it with a lower lid flap, and making them look relatively good at the end, thinking about the aesthetics. Surgery, this is a major component, and if you don't like, so the surgery, trying to, this is a large head and neck tumour invading into someone's orbit. We need to recreate her face. In this lady, we put a flap up there. So, you know, there's things that we can do.
Any other bank, but they're all quite differently structured and quite unique. So I guess another big thing that's big for us is that we partner with a lot of associations that you'll be in contact with when you're going through your studies, and then also when you start working in the hospital system. So there's a lot of great benefits that we can look at for you that way as well. Okay. So this is a big thing for us. So you'll find that every one of our clients gets an individual banker, so that when you guys, we know you're really busy, even when you're studying, there's lots of study that you have to do, so it's hard to call through to a call centre and wait on hold for half an hour and then speak to someone who doesn't really know what's going on. So every one of our clients has a specific banker that's there to take their call and help them with any product that they need help with. But one of the big things that we focus on is that when you need finance, you want there to be, it wants to be solutions based as opposed to just being a product that you're taking out for the sake of taking a product. One of the big things that we look at for a lot of our students and the things that we find you guys generally set up before you get into the hospital system is so the facilities for salary packaging, so like what the accounting firms were talking about earlier. We provide the facilities to get that to work for you. Also, when you're looking at taking your electives, helping you with getting the funding to do that. And also, we find a lot of you, once you finish studying, want to take a little holiday. Okay. So basically, this is a little bit of a rundown as to why we like to work with doctors and dentists and why we like to think that you guys should work with us. So I guess one of the biggest factors is we're here tonight. We're willing to help you now. We don't wait until you guys are earning millions of dollars and then step in and go, hey, we can help you now. We really do pride ourselves on helping you guys all the way through from when you start studying to when you're ready to retire. Okay, so this is the biggest facility that I set up for a lot of students. What it is, it's designed to help with cash flow. When you're studying, and also once you get into the hospital system, you want to get comfortable with your pay that's coming in. each fortnight, how much you're getting and what's going in rent and all of that kind of thing. So what we do is we actually give you guys access to all our primary banking products, so credit card, overdraft facilities and everyday transactional accounts, absolutely free of charge. So what that means is that you can start using your credit card and actually understand how to use it, while also having the facilities there to be able to pay it off, because you don't want to be holding debt on a credit card. It's the most expensive form of debt that you can have. So we have the facilities there to help you guys pay that off as well at a much lower interest rate. And with that overdraft facility, you don't need to start paying it back until you're working either, which is great. So that is everything I have for you. Just make sure you fill out those little slips and pop them in the box when you guys are finished, and we'll draw it a bit later on. Thank you.
Thank you for that. Everyone make sure you fill out your slips. We all have a bit of free cash. So we've got our next speaker, our last speaker, who's trekked through the rain to get here tonight. So thank you all for staying. Can I introduce Dr. Nick Carr?
We're slightly bedraggled and soggy, Dr. Nick Carr, so apologies for the appearance, but on the bicycle between St Kilda and here it started to downpour, so thank you very much. What is it about the iPhone weather app that's always wrong? I'm a GP in St Kilda. I used to lecture you guys back in the 90s. I used to give lectures on all sorts of things. I used to do ethics, I did the communication skills program, but I also lectured on coughs, colds and sore throats. And I used to say to that lecture, at the end of this lecture we'll be able to divide you guys up into those of you who want to do general practice and those of you who think, nah, not for me. And one of the reasons for that is not because cough, cold and sore throats are so fascinating, though I actually happen to think they are fascinating, but it's because the reason people come with a cough or a cold is the reason you need to know, because 90% of all respiratory illnesses do not go to a doctor. So unless you're interested in why has this person come to this doctor on this day with this symptom, then coughs, colds and sore throats are boring. But if you are interested in that, if you're interested in people, then suddenly general practice becomes a possible career for you. So let me backtrack a bit. I was a medical student in the UK. I did my undergraduate training at Cambridge University and then my postgraduate in London at Charing Cross Hospital. The plastic surgeon was saying, go somewhere exotic for your elective. I did. I went to Canberra. which when you're from the UK seems quite exotic. But it did start my love affair with Australia. So after I qualified, I came back to Australia and I worked for a locum service. Worked up in Sydney and absolutely loved the country, hated the work, but that determined that I was going to come back to Australia. So I went back to the UK and I wasn't sure, like many of you guys would be, I wasn't sure what I wanted to do. So I did a variety of different jobs and I had this sort of vague idea I wanted to do psychiatry. And I found a GP training scheme where psychiatry was one of the modules. And this is something I would encourage you to think about. If you're not sure, give it a taste. I started the GP training scheme. The first job I did was 6 months psychiatry, and I really enjoyed it. But I also got really sick of people being miserable all the time. I longed for someone to come in and say, yeah, I've got a sore throat. Everything else? No, fine. Because no one in psychiatry ever said, fine. So I found it a bit overbearing. So that was the answer to my question, no, I don't want to do psychiatry. But then I did paediatrics, I did geriatrics, I did general medicine. I enjoyed every single one of them. And when I did Jerry's, I missed the kids. When I did kids, I missed the old people. So I thought, great, I should be a GP. So that was how I discovered it, was by going through that training myself. And I was lucky enough, one of the things, again, I've heard said earlier tonight, is about make the most of it, travel. It sounds such a truism, but it is true, like truisms are. I got a chance to be an expedition doctor in the Amazon before I came to Australia. So had a couple of months wandering around in the jungle, looking after people on an expedition. This is the sort of thing you can do if you stray off the path a little bit. I was told back in the National Health Service back in the 1980s, ooh, if you don't get into a career, they'll never get a job. You know, everybody else is going straight into doing their junior trainings and that sort of thing. I don't believe in that at all. I think get on and do the stuff you want to do and have some fun. Because a medical career, whatever you choose to do as a speciality, is a great way of also having fun. One of the things I did after I got to Australia, because I arrived here and was a bit dismayed actually by what I saw of general practice, because I did locums around the place in Melbourne. This is back in 1988. And the focus was so much on bums on seats, pushing people through, earning a decent income. I found it hard to find people who were interested in academic general practice. So I enrolled to do a master's here at Melbourne Uni, which turned out to be a very, very smart thing to do, because I met the kind of people I wanted to meet. I met academic GPs. I learned a lot, but more importantly, I got connections with the kind of groups that I wanted to be connected with. And that's what led me to be working as a lecturer here. It led to my interest in quality use of medicines. It meant I worked for the National Prescribing Service. I got a job with the Pharmaceutical Health and Rational Use of Medicines Committee, which is a ministerially appointed federal government committee, very senior stuff. It was great fun. We flew business class, got all these frequent flyer points, which was brilliant. And then an airline you will never have heard of called Ansett went bust, and all the frequent flyer points went. But this is part of the point about doing different things, and one of the things about general practice is the variety of options that you have available to you. And what it gave me was the chance to do a whole variety of things, including sort of committee work. However, lifestyle has been hammered home, I'm sure, by every other speaker. And one of the reasons I chose general practice was also because I knew when I had kids, if I was lucky enough to do so, I needed time at home with those kids. And when the first child was born, the first thing I did was gave up 1 day a week of work. And that meant I had a whole day a week at home with my kids right from the start. Best investment I ever made. Yes, I drove a banged up old Commodore for 20 years. Yes, we went on camping holidays. But I have a relationship with my adult kids that my own father and I never had. And I'm sure it's partly because of that time. One of the things general practice gives you is the opportunity to choose that more part-time element. And in the end, work is only one part of it. And for me, certainly, that was one of the best decisions I made. It also led to my interest in parenting, first-time fathering, which I subsequently published a book. Sort of thing you can do if you have time wandering around in general practice, sitting at home with kids, writing books. So, what about general practice? Because you want to go home, I want to get dry, and my dogs need feeding. So features of general practice, why you should choose it, why it may be for you, why it might not be for you. Number one, general practice is not about diseases, organs, it's not kidneys, it's not livers, it's about people. And if you're not a people person, general practice probably isn't the right career choice for you, because you have to be interested in people. But if you are, one of the things I always say is we're in this era of evidence-based medicine, EBM. I get very cross about EBM. I say EBM should stand for expressed breast milk. Because evidence is about what happens when you take thousands of people and you get a sort of average outcome. In primary care, we're interested in people. And so I say the acronym should be PEBM, it should be the patient, and then the evidence-based medicine, because for us, the patient is the most important. There is someone in here for whom the EBM is appropriate. Can you see the baby in that picture? Anyone not see the baby's little heads up the top and little feet are down in the tree there? Yes. See the baby now. So I love this idea because this is about that EBM should be for that person hidden in the picture for the baby. We must, in general practice, talk about the patient, and that's one of the hallmark differences between us and hospital speciality medicine. The other thing that's terribly, terribly important, if you're thinking of a career in general practice, is you must be able to cope with uncertainty. And this, again, is not right for everyone. Remember that when roughly 50% of people who come in to see you in general practice, there won't actually be a diagnosis to make. In the 50% where you make a diagnosis, you will be wrong 50% of the time. Because disease is presenting early, because symptoms are unclear. You've got to be able to deal with uncertainty if you want to be a GP. And if that's not you, then keep that in mind. It's a very, very important point. I guess everyone who's spoken has probably talked about, oh, my work has so much variety. Well, guess what? They're wrong. We're the ones who have the variety. We have the real breadth and variety, which is good, but it's also the bad bit. If you're the kind of person that wants to have the real depth, if you want to be the person, the go-to expert in an area, don't do general practice. Because we have to be comfortable with the idea we need a huge breadth of knowledge, but we don't necessarily have the detailed expertise in any of that. And that's got to be okay. And I sometimes miss that. I would love to be the person, someone rings up. I do a lot of media. I did 3 years on television presenting health stories, and everybody thought I was an expert in bloody everything because I had 2 researchers on the ABC who found out all the information for me. I just had to spout it out on camera. I would love one day to have been that expert. I've done a lot of talkback, worked with Steve Izard and people like this on radio doing this stuff. The idea that I really, really know would be wonderful, because in general practice, I know quite a lot about some things. So if you're the kind of person who needs to be the expert, again, general practice, probably not for you. But if you like breadth and variety, oh goodness, I've got to put this in. Some people probably talked a lot about, I mean, I've published a pathetic number of papers over the years, but these are just a few of them. But one of the reasons I put this is about variety. Because if you have the ones I like best, 6 seconds therapy is how to do primary care psychotherapy, 3 techniques that take 2 seconds each. How about that, psychotherapy in 6 seconds? I love that paper. I do a lot of teaching around how to deal with doctor shoppers and drug seekers. I just want some value in doc. Again, an interest which I've just developed over time because I work in Grey Street, St Kilda, has led to a full-blown program which I teach to all the GP registrars. So you can see it's a bit of a mishmash, a bit of psych stuff in the book, but this is the one I really like. So any of you can have babies, buy the book at the bottom there. That's the only book you need. Book for first-time fathers. More importantly, in terms of breadth, what I did, this is just Thursday's consultations. I just whizzed through and wrote down who they were. And I just thought it would be interesting. I mean, you've sat in general practice, you've seen this sort of thing. But what other job do you get to do this? What other job do you get that huge variety of people? And the thing that's really exciting, I've worked in the same place for nearly 30 years, but when, where is it? 4th from the bottom, 26-year-old male, when that person was booked in, I have a new patient I know that's booked in. I have no idea what I'm going to be seeing, what I'm going to be doing. There's no other area of medicine where it's that. If you work in dermatology, you have a pretty good idea that your next patient is not going to have cutaneous leishmaniasis. It's probably going to be eczema or psoriasis. When I have a new patient, I have absolutely no idea. So a 26-year-old bloke in my area, it's often a mood disorder or something like that, because I get referred a lot of psych. But it turned out it was an American guy who'd come over to Australia and who was looking for a GP, some sexually transmitted stuff and that sort of thing. Absolutely fascinating, but you have no idea. This is so exciting. I mean, to be able to go to work every single day and feel excited about it, because I don't know what I'm going to do. And look at that variety. Fantastic. A very, very important point. If you want to change the world, don't do general practice. Become an epidemiologist, become a researcher, do community medicine, do population-based medicine, because that changes huge numbers of people. If you can treat diarrheal illnesses in developing countries, you will save thousands, if not tens of thousands of lives. So if that's your goal, that's not general practice. General practice is valuable at that individual and community level, and that matters a lot to people. But we don't save the world, but we do, I hope, help people. Another truism is this idea that we see people long term. A mate of mine said, yeah, that's why I'm an interventional radiologist. I see people once, they piss off, I never see them again. Fantastic. That's what suits him. So if you're the kind of person who prefers one-off, doesn't want the long-term connection, don't do general practice. But the marvellous thing I have is I'm now vaccinating the babies of people who I vaccinated as babies. You only get to feel this once you've been there a long time, but it is magnificent. You have this real connection with the community and the people. And there's nothing that can beat that. Last thing I want to say, there are an awful lot of bad GPs out there, because it really is the easiest speciality to do badly. However, The really, really good general practice is much harder to do than any other speciality because of that enormous breadth. So if you want to do general practice, please be one of the people who does it really well. Thank you very much.
Thanks for staying, everyone. That wraps up the night. Hopefully you've enjoyed all the speakers. I definitely myself have. Yeah, please go home. It's been a long day. Take a picture as you go home. There's still some left over.
The one that was